Hi there, I'm Chris Jackson. I'm a medical oncologist at Dunedin Hospital. I'm a researcher at the University of Otago and collaborate with Healthier Lives as the lead clinical researcher for the Circulating Tumour DNA project. I also work for the Cancer Society of New Zealand as the medical director. Cancer is the number one cause of death in New Zealand, and unfortunately over the next 15 years the number of people affected by cancer is going to go up by 50%. So we're going to have 50% more people affected by cancer every year. Already we have more than 23,000 New Zealanders every year affected by cancer, and it is the number one cause of death and disability in our country. So as a problem, it's only going to grow in terms of importance over the course of our lifetime. We have one of the highest rates of bowel cancer in the world here in New Zealand. And down south, here in Dunedin and in Southland, we have one of the highest rates of bowel cancer, which is why we have had a particular focus on bowel cancer as part of the Circulating Tumour DNA Healthier Lives challenges. Also, unfortunately, we are the melanoma capital of the world. So Australia's melanoma rates are falling, unfortunately, while ours is increasing. So we do definitely need to get the message on prevention, but certainly we also have got a real problem with treatment facing us over the course of the next 20 to 30 years. One of the problems with cancer treatments is that we often don't know whether or not they're working, or it takes us a long time to establish whether they're working because we can only really do scans every 2 or 3 months. That means people can be on treatment for 2 or 3 weekly cycles, having regular, frequent, toxic or expensive chemotherapy or immune therapy treatments, and we can be a little uncertain if they're working or not. If we had circulating tumour DNA, we might be able to work out at an earlier point if the treatment's working well and intensify treatment or de-escalate, or we would understand if the treatment was futile and we could withdraw from that. That would mean people would not be exposed to futile treatment. It would mean that more timely treatment decisions could be made so we could intervene before people's health was affected in a negative way. And we could also potentially save money by reducing the costs of treatment by using circulating tumour DNA. Also, we need better monitoring techniques for cancer. Currently, our surveillance techniques for cancer are still doing what we were doing 30 years ago, which is scans from time to time, physical examination, and very crude and ineffective blood tests. If we had a good, reliable blood test like circulating tumour DNA, we could potentially conduct much of the surveillance work which is done currently in hospitals, back in primary care and in the community. That could mean that hospitals are freed up to do work which really helps diagnose people and offer treatments that add value and that matter, and low value engagements like surveillance and follow-up, which currently clog up hospitals, could be decongested and moved through to the community. Because people who are being surveilled for cancer usually have few current health needs, they're just being monitored, and if we could move that monitoring to where they live and close to their home, we could potentially unburden the hospitals. Patients want to know whether or not their treatment is working. They want to know the treatment they're on is right for them, and if it's not right for them, they want to be off their treatment. They also want to know if their cancers come back once they've been off their treatment, and so we need more sensitive and more specific tests to work out if the treatment's working, to work out if the treatment they're on is right for them, and also once they've finished their treatment to work out if their cancers come back. These are really important questions for patients who are affected by cancer today, and they want to know those answers. Currently the tests we have are inadequate, so we need to develop better tests in order to help make sure the treatment that people have is right for them, and to make sure the cancer is picked up at the earliest possible point. In our region, we have some people who would drive for 3.5 hours just to come to hospital for a 15-minute appointment and then sit in the waiting room for half an hour and then drive all the way back. And that engagement with patients is pretty low value from their point of view. What we do in those hospital appointments is pretty limited in terms of our ability to detect recurrent cancer. So ultimately, people are driving a long way for reassurance, and that reassurance may be false. If we had tests with better specificity and accuracy, a lot of that surveillance could be done at home, reducing travel time, reducing treatment, reducing hospitalisations and need for hospital outpatients attendances, and that would mean that a whole lot of resource would be freed up in the health system and a whole lot of patient time wouldn't be taken up. That would mean surveillance for cancers could be done closer to home, it could be done in primary care, and the accuracy would be improved. People need health services that are well designed to meet their needs. I think it's well known that certain groups of our community find it more difficult to engage with hospitals, find it harder to get to hospitals, or find simple barriers like parking costs are prohibitive. Hospitals are only open during normal working hours, which also might not fit with people's schedules, and that might mean that people don't attend for follow-up and surveillance. Anything we can do to reduce those barriers to attendance and reduce those barriers to surveillance is going to improve the quality of care that people get. And if we can break down those barriers through the use of circulating tumour DNA, then we could reduce the need for people to travel to hospital and would help their engagement with treatment plans. So I think this could indeed mean that the quality of care that people get goes up. There is no doubt that we need better biomarkers for monitoring treatment. There is no doubt that we need better tests to detect recurrent cancer. There is no doubt that we need better tests to improve the sensitivity and accuracy of diagnosis. We need these tests. In 10 or 15 years' time, we'll look back on this time as an important landmark in our history and we'll wonder why our previous tests were so crude. I think this technology is here, it's here to stay, and it's important to be at the front of the wave, developing it in an appropriate way for our environment, with our clinicians, with our researchers, and integrating it into routine practice as soon as possible. The future's here now, and we need to engage with that.